our colleagues at the Physicians for a Healthy California. The President and CEO, Lupe Alonso Diaz, along with Monica, the GME Director of CalMedForce, has joined us to talk a little bit about some of the funding available not only for GME, but also for loan repayment and some of the great work that they've been doing over the last year in this space. So I will turn it over to both of them, and thank you for being here.
Thank you, Natalie, and it's a pleasure to be here. So we definitely appreciate all of the good work that you do. So it's nice to put some faces to names to emails that we've seen across the board. So thank you again for the opportunity to be here and share with you some of the good work that we're doing, as well as to hear from you what we can do differently and or consider in the future, since it is a partnership, and Physicians for Healthy California, CMA, and CPCA have always had a very strong partnership, and it is our interest and our intent, obviously, to continue working on that very strong partnership that we have in place. So thank you again for the opportunity to present to you. So I'm just going to do the super quick overview of who we are, and then Monica will present on GME, and then I'll wrap up by presenting on the loan repayment program. So as you heard from Natalie, we are here representing Physicians for Healthy California. I'm the President and CEO, and Monica is the Program Director for our GME program, which, as I can see already, we have some awardees in the room, so we're super excited to see that. So just in terms of our presentation to you, you'll hear directly from us with respect to GME, the Graduate Medical Education Residency Program. It directly supports programs, and it is administered by Physicians for Healthy California. The funding is provided to the University of California, and then we in turn administer the program. The other program is the loan repayment program. That one, the funding flows from the Department of Healthcare Services to PHC, and we also administer that particular program on behalf of the state. Both of these programs are funded by Proposition 56. The GME program is specific to residency programs, to supporting, sustaining, and retaining graduate medical education and focusing on direct medical education costs, whereas the loan repayment program is specific to individuals. So it is specific to the who, so who supports you, and obviously your physicians and your dentists that directly work with you are the key core primary candidates that we want to see as we're evaluating applications and as we're making awarding determinations. So that's a little bit about the work that we do. We are a 501c3. We've been around since, and don't quiz me on this, it's either 1958 or 1963. I don't remember. I should probably know. Oh, there it is, 63. And we knew it. And we were, and what's ironic is that we actually were formerly known as the California Medical Association Foundation, and we just changed our names less than a year and a half ago. And we ironically changed our names because we wanted to decipher that we weren't a typical foundation. We weren't like the California Endowment. We weren't like the California Healthcare Foundation, and we're still not. We're not like that. But the reason why we wanted to make that distinction is because as an organization, like many of you, we not only receive funds, but we also disperse funds, but we primarily receive funds. And so in this particular case, it's kind of funny that our two flagship programs, the programs that we are most excited about and that have been with us most recently are about dispersing funding. So we are actually very much operating like a foundation, but we've changed the name foundation out of our name. And this is more in recognition that our work is also to more broadly support not just physician workforce development, but other areas like community health and health equity, and that doesn't necessarily always come to the forefront when you think of the California Medical Association Foundation. So as you can see, our mission is threefold. It is physician workforce, and specifically diversifying the physician workforce, and then prioritizing and promoting health equity as well as community health. And so with that, I'm going to, I think we talked a little bit about this. We do have another program called the Network of Ethnic Physician Organizations. We are the only statewide organization that works really closely with local and regional ethnic organizations to promote some of the good work that they do. So with that, I am going to, oops, oh, I got a little too happy with the button. So I'm going to pass it on to Monica, who will share information on our GME programs.
Yes, thank you, Lupe. And I just want to state that if there are any questions while I'm going over this, please feel free, raise your hand, jump in. Definitely want to make sure that this is interactive, but also useful for all of you, too. So as Lupe mentioned, in 2016, there was Proposition 56. This is how we actually receive our funding. The funding actually goes to UC, in which then we are contracted with UC for $40 million. So the whole goal is sustain, retain, expand GME programs. These are the statutes that really create us. As you can see, there's only a few lines of statute. When we think about what are our requirements, what do we require of our awardees, this is all based on different conversations we've had with our advisory council, our board, ultimately UC approval. But when we think about how flexible we can be pretty flexible because there's only really a few lines that lay out our program. And here's actually the organizations that make up our advisory council, so part of our governance structure. And of course, you will notice that CPCA is on here. So you have a wonderful advocate for all of you with Natalie and Debbie Lupica. So they're definitely a big part of the advisory council. And we also have the board as well, which is made up of PHC, CMA, UC, CHA, and SEIU. So when we think about our CalMedForce mission, this really is to grow a diverse physician workforce, supporting, incentivizing, and expanding GME in California. And I won't read the rest of it to you because you can read that, but it is really something that we try to make sure that, yes, we have statutory language, we follow this, but beyond statutory language, we also have this other mission of diversity, a health workforce, really thinking about how can we increase primary care physicians and emergency medicine physicians in California. How do we do this? And so our mission is beyond the statutory language. So at all interims, we try to really make sure that we follow our mission. So thinking about the timeline. So it's also important to note that this program really began, August 2018, so a year ago. And so within a few months, we actually put together the application, the grant guidelines, all of the components that really make up our grant program within a few short months. And I'm sure some of you applied and sort of was with us during the growing pains process of, oh yeah, we forgot to put this on our website. Thank you for that feedback. And so there was a lot of process and pieces that we were putting together as you were all applying. And so now we've gone through that process. We've awarded the 2018-19 awardees. So now we're already getting ready to launch for the application, which will be in September. So September 23rd is our next grant cycle application. And so I'll get into more details about this, but definitely want to make sure that this is on all of your calendars. If you received funding last year or if you didn't receive funding, everyone is still eligible. And so the same eligibility is still there. So definitely want to make sure that this timeline makes it on all of your calendars. We will be closing the application October 28th. And so thinking about the future, what are going to be the application cycles in the upcoming years, we're still working on those details. So, we will try to keep with a regular schedule, but definitely want to let you know that, as I'm sure you can guess, it's an evolving program. So it's based on feedback from all of you that if the September-October cycle, if that was really difficult or you were unable to actually have the adequate amount of time, we actually send out surveys. We want to get all of your feedback. And so, you can actually help shape that if September-October doesn't work for all of you, and we've heard that from multiple people, then we will change the application cycle. So just want to make sure that you keep that in mind. So when we look at eligibility, so it is the same eligibility as the previous year. So allopathic, osteopathic, California, primary care, emergency medicine. And you also must be accredited by ACGME. And we do give priority funding to programs that really look at serving the medically underserved areas and also populations. So for the previous cycle, this was actually the funding disbursement across all 5 specialties. So these were actually the awards. So you'll see family medicine received 9.6 and the total amount given, 38.195. So when you think about how much is given out, that's for the previous grant cycle. We again are going to have another cycle giving out another 38 million. So that is definitely very exciting, definitely an opportunity for other programs to be encompassed in thinking about who are the awardees. So there's definitely another chance. The requests for the past cycle, we had a great turnout. We had a total of 131 applications submitted last year. There was a huge request for funding. And this we can note by 147 million that was requested by all residency programs. Unfortunately, we only had 38 to give out. And so it is a very competitive process. Here is the depiction of where all of these award programs are. And a nice glossy brochure as well. So this really lays out that all of the awardees, they're dispersed throughout California. And so want to make sure that you're aware, as an advisory council, as a board, with UC, we work to really make sure the application process is fair, it's equitable, that if you're in an urban area or if you're in a rural area, you have the same opportunity to receive funding. And so you can see that there's really great disbursement across California in the awardees. So when we think about of the 72 awardees, there were actually 6 community health centers that received a total of 2.7. And so we would love to see this number go up. And so definitely we encourage everyone to apply. So just wanted to highlight some of these programs that we are actually awarding for this past cycle. So key highlights, dates to remember, really want to make sure that you all are aware the application cycle will open on September 23rd. And something different that we're doing for this year is that if you send in your application by October 11th, we will send you a preliminary score so that you will know this is the score with the information given. This is something we did not do last year, but we really want to incentivize all programs to submit their application in early. We want to be able to work with you. And so this is a way in which we can really make sure that if there's a document missing or if something's not correct, we can actually have a conversation because you've submitted your application early. That being said, if you submit your application on October 12th, we will deem that as a final application. So we are very much trying a hard line that if you submit it after that date, it's a final. We're not going to give you a call and say you're missing a document. It's very much expected that from the grant guidelines, it's pretty clear of what needs to be done. But of course, that being said, we will answer any questions that you have about the application process. So just want to make sure that you're all aware of this difference that we're doing for this cycle. We are planning to make funding announcements at late November, early December. We do recognize that, of course, all programs want to know right away. So we are definitely trying to make every effort to get the funding announcement out as early as possible. Changes in available funding. So it will be 38, and then the next slide will have the exact amount for each specialty that I'll go over. We already talked about the preliminary score. The AOA accreditation, any program that has AOA accreditation must be actively working towards GME accreditation. And then this is the different funding structure that we have for this upcoming cycle. So for family medicine, the amounts awarded will be 9.5, and then for all the other specialties, there will be 7.1. When we think about how much you could receive per resident, that is based on whether your program is new, existing, or expanding. And so there are different funding categories. So we are finalizing all of the FAQs, the grant guidelines currently. We will be posting all of this on our website in the upcoming weeks so that when you're looking at this and you're wondering, how does my program classify, you'll be able to look at our grant guidelines and know exactly how much you'd be eligible for.
Monica?
Yeah.
Question. Sorry.
Yeah.
If I'm starting a new program
Mhm.
and I want to bring in a first year class and maybe even the second year class
Mhm.
with my first round, can I apply for 5 slots for first year and 5 slots for second year?
So that is a really good question. The way that we have funding, and we'll put this in our grant guidelines, is that the funding is for the PGY1 class.
Okay.
And so say you had 2 PGY1s, but you had 3 PGY2s, you'd only be able to request funding for that PGY1 class.
Thank you.
Yeah. So are there any other questions that I can answer right now?
I had a question that's a little in the weeds. So a couple slides where you're talking about the new and existing.
Mhm.
If you got planning money the first time and now we're accredited and you're applying, we are now then existing because you've got something from the first, but we're not an existing program because we don't have residents, but we got we're confused. So
Yeah.
maybe that'll be answered in the FAQ, but.
So I'm glad that you asked, because I'm sure there are other programs that also have the same question. So with that specific example, for us, for CalMedForce, our definition of new is that you have not graduated any cohort of residents. So you could potentially have PGY1 filled, PGY2. You would still be classified as new because you have yet to graduate any residents at all. And so our definition of new is fairly broad because we recognize the cost of actually setting up a residency program. You're not going to encumber this within the first year, the first 2 years. It's going to take some time to recover from that huge expense. And so we do have a broader definition of a new program.
That's awesome, because our folks were thinking we were existing and we were going to compete with people who already had doctors and ours were not. So, good answer. Thank you.
The Songron structure is a little different, so when we hear from OSHPED in the next presentation, we'll hopefully be able to tell the differences. They define them a little bit differently.
Yeah. And I was going to say that it sounds like if you received planning money, you probably got it from Song Brown, not from us. And so I just want to point that and highlight that CPCA and the California Academy of Family Physicians were very strong advocates on your behalf with respect to the definitions and ensuring that our definitions of new were expansive enough to address that there were going to be some new programs that would be challenged because you would have, depending on when you applied, you would have received planning money and then, like you said, competed with everyone else. So I just want to highlight that definitely your team of representatives that are on the advisory council do a really good job of advocating for you.
Natalie.
Yeah. Yeah.
I'll second that.
Right there. Thank you.
Are there any other questions? All right. So just want to point you to our website. We'll be uploading a bunch of materials in the upcoming weeks. Also, you can follow us on LinkedIn, Twitter. We do have an email update, so if you would like to subscribe, you can send subscribe to the CalMedForce at phcdocs.org to receive all of these updates. And of course, you can also call us. There will be a live person answering on the other end to answer any of your questions as well. And so with that, I will hand it off to Lupe. Oh, yeah.
So only 6 of the awardees were FHCs, and the priority is to give awardees that are working in the program. So I guess I'm surprised that there wouldn't be a higher number.
Well, only 6 community health center residency programs applied. So all of the ones in the last cycle got funded.
All of the community.
It's
Okay.
because recognize that in order to apply to this program, you have to be accredited.
Okay.
And there are a smaller number of accredited programs than there are health centers engaged in GME at large. So that's part of the reason.
That is a good fact. We will make sure to highlight that. So that is a good record that all of them that applied received money. So yeah. Okay, great. All right, so any other questions? I will hand this off to Lupe. And then also, if you think of something later, please feel free to email us or call us. Always want to make sure that we connect with all of you.
And Monica is super humble, but I am not. So Natalie knows that. She, with her leadership and my support, she actually launched this program in 3 months, and that is a huge undertaking. And so kudos to you for doing that, because it really was her on a day-to-day basis, making sure that, I mean, literally standing up a program that has 2 to 3 sentences in the statute, meaning, will we have an application? Will it be competitive? Will it be first come, first served? Will it be, what do we ask in the questions? Will it be electronic? Will it be paper-based? How will we do marketing? How will we reach out? I mean, all of that stuff was done literally in 3 months. And I think thanks to Monica's leadership, it definitely exemplifies that we are very responsive, we're flexible, we're nimble. And in the areas where it's just a no, we're also pretty good about saying, sorry, that's just a no. But I think for us, what's important is not, in addition to the representation on the advisory council, we truly mean it when we say that we want your feedback, we want your feedback. And it may not necessarily be something that we can incorporate immediately. It might be something that we'll have to mull over, and there'll have to be a little bit of strategy behind how we're responsive to your request. But we are definitely responsive to your requests, and we're always asking for feedback. As Monica mentioned, our timeline is constricted. We're already talking about year 2, but really it's been only 12 months and we're already launching the second cycle. And normally you'd have enough time to be able to launch a cycle, make awards, do a little bit of monitoring, learn from that process, and then you relaunch again. And one of the things that we did in our program from a process perspective is that we're constantly asking, what does this mean for you? How do we do things differently? Are we being responsive? And so it was after we received applications, we did go back and ask our applicants, not just the awardees, we asked our applicants, does this time work for you? Should we be releasing applications in this time frame? And overwhelmingly the answer was, nope, that timeline doesn't work for us. We want to do it before match day. We want to make sure that we know that we have some funding before we go through the matching process. That makes sense. That was something that we were so focused on, like just launching the darn thing, that we oftentimes forgot, oh yeah, there's this thing called match, and perhaps you need to know whether you have funding before you go forth and do that work. So that's just one example of how we're responsive and how we're always taking feedback into account. And even if it appears that we're not able to incorporate it in the immediacy, we're always constantly thinking and learning from that process. And I would say that would be the same philosophy that we use for the loan repayment program. And this one is also a really good wonder of, holy moly, like, you want us to do what? So we launched the loan repayment program in 3 months because we're very competitive, and so we wanted to one-up ourselves. And so this program actually started, so this is the loan repayment program, and it actually, and I'll go through a little bit of the history, it actually started as an initial investment of $220 million, and then you'll see that through the process of stakeholder feedback, as well as through the process of the applications, we received an additional $120 million through the May revised process. And I think that shows the strength of the community in saying, no, this is a thing, this is important. And in order for us to ensure that we have physicians and dentists at the ground level working with Medi-Cal beneficiaries, we need more than 220. So this is our mission statement. It's very simple. It's about increasing and incentivizing additional physicians and dentists to support Medi-Cal beneficiaries. So in our program, we do support physicians and we support dentists. So unlike other programs like Steve Thompson, this one is specific to physicians and dentists, and we do administer both of them out of Physicians for a Healthy California. Our goal here is to do 2 things. One is in terms of supporting and incentivizing existing physicians and dentists to stay in Medi-Cal, particularly if they have a high Medi-Cal penetration rate, then our goal is to keep them there. So how do we do that? And then the other goal is for those physicians and dentists that don't have Medi-Cal, that don't participate, that are literally at 0% or negative 0%, the goal is also to say, what would it be like? What would it take for you to become a Medi-Cal provider and stay at least 30% of your patient caseload? So the goal is twofold. It's to both bring more Medi-Cal providers into the system, and it's to also keep those that are already in the system. So this is the Welfare and Institutions Code, WIC 14114. So if you wanted to ever wonk out with this, this is the statute, this is the governing authority that allows us to do this program. It's officially known as the Proposition 56 Medi-Cal Physicians and Dentists Loan Repayment Program, otherwise known as CalHealthCares. And you'll see that very similar to GME, that the statute is broad enough that it allows us to work with the department and it allows us to work with our stakeholders to identify what would be of the biggest impact for our community. At the end of the day, both programs are funded by Proposition 56, and there's an overall intent in the author's drafting of the initiative that this go back and support underserved communities. And you see that very specifically in the way that the statute is written, both for GME and for loan repayment. So we already mentioned this, DHCS, the Department of Health Care Services, Jen Kent, and her team is responsible for the oversight of the program, and they've contracted with us to administer the program. And so as you heard me mention, so the original statute in the language had us at $220 million over the course of 5 years. This is a one-time appropriation, so I should make that very clear. What that means is that when we initially received the funding from DHCS, it's $220 million over 5 years. The initial goal was to make it a one-time program. That remains the goal of the program. It is a one-time appropriation. So for the original $220 million, we did divide the funding up across the board equally over the next 5 years. So we had some funding this year, and it'll be the same funding next year. When we heard that we had an additional $120 million, also a one-time appropriation, also over the course of 5 years, then we actually upfronted a little bit more of that $120 million in years 1, 2, and 3, with a goal of hopefully getting more funding sometime in years 4 and 5 so that we can keep the program as an ongoing appropriation. So these numbers aren't exact, and that's because every year the numbers will fluctuate a tiny little bit, but just to give you a general estimate of where we're at, so it's $340 million over 5 years. Again, that's a one-time appropriation. It's for physicians and dentists, and you can see that there's a split between dentists and physicians. So annually for physicians, we're talking about $58.6 million and almost 200 physicians per year. And for dentists, it's about 10.7, almost 11 million, and about 36 to 40 dentists per year. The biggest assumption here, and I'll talk about it, is that it assumes that it's a 300,000, it's an up to 300,000 loan. So these numbers assume that we're awarding almost everyone at 300,000. And I'll go into that into a little bit more detail in the next slide. So in terms of the loan repayment program, it's very similar to what you probably know. It's not a loan forgiveness program, so we don't forgive loans. We're not in the business of forgiving loans, nor do we have the governing authority to do that. We repay loans. So what that means is that we work with physicians and dentists that have existing educational debt that can prove that they have that educational debt via their pursuit of their medical degree or their dental degree, and then we help them repay their loans. And we can repay up to $300,000 in exchange for a 5-year service obligation. The $300,000 is a really big deal. There is no other, and we've done the research, there is no other national program that even comes close to this. Steve Thompson is 105 over 3 years. I know that because it's an awesome, excellent program, and I administered that program a few years ago. There is no other program like this. It is $300,000. Why $300,000? Well, the average debt, according to a lot of research for physicians, is about $265,000 to $270,000. So when they graduate from their residency, that's how much debt they have. What we saw in our applications that we received is that the average debt was actually closer to $300,000. So almost everyone that received a loan repayment from us received really close to $300,000, and that's because that's how much debt that they had, that they were able to prove that they had. Now, what's fascinating is that for dentists, they actually had an educational debt load that was much bigger than physicians, and that actually makes sense when we think about it. While physicians go through medical school and then they go through the residency and then they might have fellowships and training after that, for dentists, most of their training, both clinical and didactic, occurs at the dental school level, and dental schools are oftentimes twice as more expensive than medical school. So even though their educational timeline might be shorter, it's way more expensive. So they do it in a much more constricted time frame, but it's more expensive. And we saw quite a few dentists and physicians, but primarily dentists that were owing $800,000. We had one that had $900,000 in debt, and particularly the person that was at $800,000 was a dentist, and that particular person was at 100% Medi-Cal. You know that that person does not do it to get rich. They're never going to get rich. I mean, that is way more than our mortgage times two for most of us. So they do it out of a love for service. And so this program is an opportunity for us to say, we don't want you to make those decisions. We don't want you to have to be strategic about, do I do what I'm doing for the love of service, or do I make money? Can you do both? Is there a way to do both and maybe perhaps not get rich out of this, but live well enough that you build a community where you live, you fall in love, you have babies, you buy a house, or you buy whatever, you stay in that community. And wouldn't it be awesome if we were to do that in the Inland Empire and in, places across the street from Tijuana and San Isidro or in Siskiyou? And so that's what this program is about, is can we get to young physicians and dentists before they're having to make major lifestyle decisions, so that if they're thinking that they'd love to do it for the love of service, for the love of Medi-Cal beneficiaries, that this is an option for them. So another interesting distinction is that this program is for all specialties. So unlike some of the other programs that focus in primary care, this is for all specialties. The way that we did it this year is 50% of the funding for physicians went to primary care, and then the other 50% went to specialists. The reason for doing that is that the research bears out that while there is definitely a shortage of physicians in primary care with respect to the number and the geography, and there's not the same level of shortage for specialists in terms of number, and it's more of a geographic challenge. Those numbers don't bear out when we're talking about Medi-Cal. So when we're talking about Medi-Cal, the shortage is a shortage is a shortage, and so whether it is family medicine, OB, or whether it's gastroenterology, you're still likely to have a whole lot of shortages and a whole lot of wait times before our patients can see a physician. So that's why it's open to all specialties. The big difference here in terms of the up to 5 years service commitment is it is 5 years, so it is a commitment. And hopefully within that time frame, they decide to stay in those areas, which is where the GME program is important, because we know that the physicians are likely to stay in the areas where they train. So with the GME, the goal is let's focus and incentivize and support and award FQHCs and other residency programs that are in those communities, and then let's find a way to keep them there. So once they train there, we keep them there. With this program, it's not about where you serve, it's about who you serve. So unlike Steve Thompson, which focuses specifically on, do you work at an FQHC or do you work in a different area, HIPSA related, this is about purely who you serve. So again, this is looking at 30%, and we'd like at least a third of their caseload to be in Medi-Cal in order to be competitive. Now for a dentist, and we actually received quite a few dental applications from folks that are associated with FQHC, so that was really nice to see. And so for dentists, we have another opportunity. So in addition to a loan repayment program, they can either choose to apply for a loan repayment or they can apply for a practice support grant. The practice support grant is something new that we're trying. There is only one other program in the nation that has it, and that's New York. So we took a little bit from New York. This supports their practice. So this is dentists that are interested in either expanding, locating, and or completely just moving to a different part that we've identified as a priority area in terms of shortage of dentists. So this is not a repayment for the dentist, but this is to support their practice. So this is folks saying that they want to practice in other areas, and again, we've identified what those areas are. This is a 10-year service commitment, so unlike the loan repayment program, this is a bigger commitment. The loan repayment program is tax reportable but not taxable, whereas the practice support grant is reportable and taxable. So that's one of the big differences for folks that are interested in one or the other. That is the biggest difference right there, in addition to the 10 years. So the award criteria, we did post a lot of this information on our website, and I should say that both for GME and for loan repayment, we do publicize our what we call the scoring matrix. So we do publicize what are the questions, what is the score associated with it and how we will determine awards. And so this is a summary of the core areas that we look at. So I already talked about current and future caseload for beneficiaries. So we both looked at what is their Medi-Cal beneficiary rate right now? What do they propose to do? We obviously very much closely looked at folks that were at 0% to see if we could get them to at least 30%. And then we also looked at providers that were perhaps at 60, 70%. And we know that getting them from 60%, 70% to 100 is probably not reasonable. And so we looked at how do we keep folks that are at 60 and 70%? How do we keep you where you're at? We also looked at specific shortages in specialty and language, so their use of language, and that's a proxy for cultural competency, since we're not able as a state to look at other proxies or more direct factors like race and ethnicity. We're not able to do that. We also looked at practice area and setting, and then we looked at their personal statement, so their commitment to underserved areas. For both programs, I would highly encourage you that if it's you or if you have someone on your team in your office that does a lot of the recruitment, I would highly encourage you to talk to us so that we can help work with you in terms of as you're hiring folks, as you're thinking about recruiting individuals to your team, to your organization, how do we leverage each other's support, because it's a win-win for both of us. So I would say that if you have any homework, it would be at the very end of the slides. Take down our contact information. We'd love to help you with your recruitment efforts. There's no other way for us to know where your shortages are unless you tell us. As an example, we do have, and this one comes up all the time, there's 5 surgeons, and I'm going to get the county wrong. I want to say that there's 5 surgeons in, it's not Modoc, but there's one county where, it's not Siskiyou, it's right next to Siskiyou. Humboldt. Thank you. There's 5 surgeons in Humboldt, and 2 of the 5 are a husband and wife team that are in their late 60s. And they've been wanting to retire for a very, very long time. They've not been able to take vacation together in more than 15 years. And that's because their love for the community is one that they know that if they take vacation, well, that's 2/5 of surgeons are no longer in the county. So while that seems like an anecdotal story, and it is, but it is based on facts, the truth is that we won't know how to prioritize unless you give us that anecdotal information. And then we can tie that with the stats that we know so that when we're working with the Department of Healthcare Services, we can say we shouldn't just look at HPSAs, we should also be looking at these other criteria. And that's where you all come in and helping us to further strengthen the program. So you'll see here that we were so naive when we first started this. So when we launched the program, we were talking to the department. We were putting, like any good program, like any good organization, you put outcomes out there. You identify your metrics of how you're going to be evaluated. And so they asked us, well, how many applications do you think you're going to get? And we said 300. We're going to be so good if we're at 300, maybe 400. We'll be awesome. And, fist bump. And then the first week, I think we trickled in like 5 or 6, and we were starting to get really scared. You build it and they don't come. And then the second week, maybe a few more trickled in, and we thought, okay, somehow we must have missed the mark. We have to figure something out. And then by the 3rd week, we literally jumped from maybe 100 to about 500. And I'm not sure what happened. We're still trying to figure that out. But as you can see, by the end, it was almost, I think it was 1276, so it was almost 1,300 applications. And it was very overwhelming emotionally from that perspective, because we care and because we want to be good partners to good government. And so when we saw these numbers, I would say that the story is legit, which is there are a lot of young physicians and dentists that want to take on Medi-Cal, that do this for the good of service. And there's a lot of challenges. Obviously, the reimbursement is one of them. And so this program can help them with that. You can see that out of almost over 1,000 physicians, we awarded 122 primary care providers and 125 specialists. So almost nearly balanced for dentists. We received 241 and we awarded 40. You can see the dollar amounts there in terms of both the award amount and the average debt load, and I apologize because I did give my numbers wrong in terms of the average debt load for physicians and dentists. But you can see that the average debt load is quite high, and that is something that, that is part of the story as well when we say, why is this program important? So we were very much overwhelmed by those responses. So in the middle of our cycle, and this is why I say that advocacy is super important. So we launched this program in the first full week of April, and I believe that by the second week we were still about 100 applications. By the third week we were definitely at over 500. That was right before the release of the May revise, and that's when we started having conversations with the department saying, I think we're going to get more than 500 because we're only halfway through the cycle. We're probably going to get some more. I don't know how many. And it was through a lot of advocacy by a number of different organizations that we went from having an initial funding of $220 million to the $340 million. So we did get almost half as much money during the May revise to acknowledge really there is definitely a demand for this program. There's definitely a demand for individuals that want to practice with Medi-Cal beneficiaries. So I'll wrap up by just quickly going through some of these. You can see the stats there just in a different fashion in terms of our awardees that we received. One of the areas that is super fascinating for us is in terms of the number of, we call them students, but they're trainees, residents that applied, and that's going to be an area of focus for us in the future, which is working that much more closely with residency programs and or other FQHCs that have clinical rotations so that we can get to them much earlier on. Obviously, this was our first year, so the application doesn't necessarily always reflect need. This was our first year, but in future years, we'd love to be able to get to residents much earlier on before they're making major lifestyle and or career decisions about where they'd like to serve. This one is super small, and I have to get closer to for that reason. So for this, you can see that this is for physician specialties. Family medicine is the very first one, which makes absolute sense. So we received the most applications from family medicine, followed quite closely by emergency medicine, is that one, peds, and then you can see there general internal medicine and psychiatry. So between family medicine, emergency medicine, peds, internal medicine, and psychiatry, that made up the top 5, which is really fascinating to see. And it also reflected the level of awards that we received. And then you'll see across the board that there's obviously a whole lot of other specialties that applied. This is for dentists, and you'll see that for the most part, it was primarily general dentists that applied, and it was primarily from either their individual practice and or small programs or FQHCs as well. So I'd like to just wrap up by saying that we were wrapping up what we call year one in terms of beginning to, we've sent out the contracts, we've sent out all of the award notifications for year one. We're already starting to plan for year 2. And so although we launched this year in April, the feedback that we got from our applicants for the loan repayment was, yeah, April doesn't work for us. We're wrapping up our residency, we're wrapping up taxes. This is like the worst, month of the year for us. So when we asked them, okay, so, when would you like to see it? They said in January, because in January it's the beginning of the year, it's fresh for everybody. For young residents that are about to graduate that are PGY 3s and 4s, they're at that time, that's really when they're starting to finalize career decisions in terms of interviews, etc. It's also when they start collecting other financial information for their taxes. So that's why we really crunched together our timeline. And so for the 2020 cycle, it'll be January 13 and the deadline will be February 7th. And our goal is to be able to notify individuals by May. I'd say if I didn't mention it for both programs, both for GME as well as for loan repayment, we do we do application webinars, and we try to do them both before the application launches as well as during the application open cycle period. And the reason for doing that is that oftentimes as adult learners, it might take us 2 to 3 times to hear something before it makes sense to us. So it's always an opportunity for us to be able to share with folks, these are the questions, this is how you'll be graded. Start collecting this information because once the application hits, it goes live and then you've got a lot of other things to worry about. So very similar for both programs as we do webinars before, during, and then after. And we also do after award webinars for applicants that didn't get funded so that we can do lessons learned and we can go through. These are some of the common mistakes that we saw, or these are things that you can do differently next go around. So here is our information right there, and I also have some business cards that I'll pass around for folks. Just passing them that way. So here's our information, CalHealthCares.org and or phcdocs.org. Either way, you can get to one of us. So again, always happy to entertain questions, feedback, anything that you might have for us. So I know Melissa's here. I don't want to take from your time. Questions? I'm sorry.
So for the CalHealthCares, I know you have to be free from any service obligation like the NHSC. For 2020, when does that service obligation need to end for someone to be eligible for 2020?
Really good question. So yes. So for the loan repayment program, you cannot be participating in any other loan repayment program, and your service obligation with that other loan repayment program has to end before our contract starts. So you can apply even if you're still under another service obligation, but that has to end by June 30th since our contract deadline for this cycle will be July 1. So by the time that folks sign on the dotted line July 1, they have to be free from any service obligation. So, and that would be different than the federal public service loan forgiveness program. So if folks are under the federal public service loan forgiveness program, they can still qualify for our program. And that's because they're different. And for the public loan forgiveness program, there is no service obligation.
Question?
Oh, okay.
Can you talk a little bit about how you're defining, for your purposes, an underserved area or maybe an underserved population as well?
Definitely. That's a good question. So Mike was asking about medically underserved areas and populations, and I'll have Monica respond in terms of GME. For CalHealthCares, we looked at payer mix as one of the driving factors. So we looked at the patient caseload for our individuals, and we provided a lot of flexibility in terms of how our providers could define patient caseload. It can be payer mix, it can be panel of patients, it can be annual visits, and or any other combination. The data that we ask for has to be self-attested auditable, so we have to be able to, they have to self-attest that it is true and accurate to the extent of their knowledge, and then we have to be able to audit it in case we needed to go forth and do that. And one of the reasons we're doing that is because it is public money. So it is the people's money, and we have to treat it that way. And for all Proposition 56 funds, it does require a biennial audit. So every 2 years, there will be an audit of all Prop 56 funds.
And would that be over 30% Medicare? Is that how you
Yes.
consider?
We look at both their existing patient caseload as well as their proposed.
I'm actually kind of curious about the cultural competency and language component because we actually kind of noticed something, and I'm wondering if this is happening in your application cycle at all. So we did an application cycle for a summer program, and that was one of our criteria to try to, enroll students who are underrepresented minorities in medicine. When I noticed that it did, when we were categorizing, we gave points for being bilingual. But then what that automatically did was eliminated a lot of Black and African American identifying students who are not bilingual, but were still very underrepresented minorities in medicine, and had to recalibrate. So did you have that issue at all with your application, not being able to ask race and ethnicity, and then on top of that, did you find that you were not able to award?
That excellent question. I think that is the crux of the policy debate. Is how we know what the policy issue is, which is that there are a number of key communities that are underrepresented in medicine. We know that the data exists. There should be no question about like who those communities are and why it's important to identify those communities. The challenge is that by statute we are unable to provide additional preferential treatment for specific categories based on race and ethnicity. So we can ask for the information, but we can't do anything with that information. So, and we asked for race and ethnicity so that we could see what our applicant pool looked like, to see if it was representative of California's demographics, of medicine in general. I'll say that for our applicants for CalHealthCares, our applicants were overrepresented in African American communities, Latino, and I believe that they were on par with APIA. What the challenge for us is if we can't use race and ethnicity, then what other proxies do we use? So language was one of those that we used, and we recognized that that would advantage some communities and disadvantage others. So then in the personal statement is where we asked, tell us more about yourself. Tell us more about your background. Where did you grow up? What about your background makes it meaningful in terms of working with underserved communities? So we tried our best to find different ways to say, tell us about who you are and why who you are fundamentally matters. That's always going to be the big policy question. Outside of 209, it's just really, it's just not as easy. But I'd say that the Advisory Council is exactly the place where we grapple with those issues, because we all have to also be transparent about what we do and how we do it, which is why it's important for us that it be noted that we do have an Advisory Council. A CPCA participates in the one for GME and for loan repayment, and that as we're making decisions about who's eligible to apply, we're also being transparent about who gets awarded, and we actively work with the Advisory Council to identify those awardees. It's not something that gets done by the department or by PHC. It's a group effort. It's a good question, and I wish I had an answer for you.
Similar to that question, but in a different way, and in the evaluation matrix for loan repayment, how strong are the HPSA scores? And the reason I ask is because if you're talking about a population that's serving Medi-Cal, where we as FQHCs do that, but in San Diego, our HPSA score is not going to compete with some of the areas in the north. And so all of our providers got denied from this program and are hesitant to apply again, believing that the HPSA score is just not going to make them marketable or eligible or get the money. And so I was wondering if you can talk a little bit about that.
Sure. It's like you're looking into my soul. So for HPSA, and having worked at OSHPD and being very familiar with the advantages and disadvantages of using HPSA primarily is in our first year, because we launched so quickly, HPSA was the easiest way to identify shortage areas, and that was what we went with. And I want to say that it was 5 points out of 40. So folks should not have been discouraged from applying for the loan repayment program because it was only 5 points out of 40. And then for dentist and practice support, it was 45 points total. One of the things that we might do differently, and certainly I'd love your feedback on this, is what we did with GME is Monica, let me know if I got this wrong. So I think for GME, what we ended up doing is acknowledging that there was different ways, obviously, of defining MUA, MUP. So I believe HPSA was 2 points and priority counties was 3 points. So we're playing around, to your point, we're playing around with, is there a different metric that we can use in loan repayment to say, well, HPSA isn't the only answer. And we did actually come across, to your point, we came across quite a few applicants that we thought, oh, that cannot possibly be your HPSA. I know you're in the Inland Empire, and then we'd do the same thing and we'd say, oh, yes, you are. Interesting. Because it's either an outdated number and they haven't reapplied, or it just is. And so for GME, they also looked at payer mix as a way of saying, particularly for residency programs, you don't really get to change where you are. You're located where you're located. That's not going to change. But what could change is your payer mix. What could change is who you see. They have a lot more influence in that area.
Similar process in the loan repayment side of that?
That's one of the issues that we'll grapple with in our advisory council. So as we're preparing for our launch in January, that's going to be one of the questions that the advisory council has asked us to reopen is HPSA the thing that we should ask for? Should it still be 5 points, or should it be more like GME where it's 2 points, 3 points, but you also identify that there are other counties that for whatever reason might also be identified as priorities. So Siskiyou, Butte, Glen, Merced, Fresno, whatever it might be. Good question. Okay, I got the, so if there's no other questions, or even if there is, again, I think my business card was passed around, so thank you on behalf of Monica and I. Thank you so much for the opportunity to present to you, and we welcome your feedback, whether it's directly to us or through Natalie and Mike, etc. Thank you again for the opportunity to be here.
Thank you.
Thank you both. So we're going to move right along into a presentation on the Song Brown program. As many of you know, there's a primary care residency funding available through that program. Funding is sort of separated out a little bit differently. So Melissa, who is the manager for the Song Brown program, will walk you through some of those differences and how you can take advantage of that funding if you're looking to become an accredited program. She's been with the organization and with the program for quite some time, so she has a lot of wisdom that she can share with you. So thank you very much, Melissa.
Thank you. Good afternoon, everyone. I'm happy to be here today to talk to you about the other GME program in the state of California, being the Song Brown program. For those of you, let me see if I can get this right here. For those of you that may not know very much about the Song Brown program, the Song Brown program was established in 1973 through legislation that focused on primary care, advancing family practice at the time in 1973. We are now probably close to 50 years as a program, and we have grown to now include internal medicine, OB-GYN, and pediatric residency programs as well. We also support family nurse practitioner, physician assistant, and registered nurse programs. Song Brown provides grants to residency programs to incentivize them to train residents that will go on to practice in areas of unmet need, to provide clinical experiences to those residents in areas of unmet need, and to attract and admit what the Commission considers to be underrepresented minorities. As I said, we fund the disciplines listed there. We work in conjunction with the California Healthcare Workforce Policy Commission. That is a 15-member body that provides healthcare expertise to us, sets policy for the program, and recommends awards. So getting back to what the statutory priorities are for Song Brown, again, they are providing residents clinical training in areas of unmet need. We want to know, we want to see when you submit an application that you are providing as many opportunities as possible to your residents to train in underserved areas or with underserved populations. We capture that information through, you will give us a list of all of your training sites, the names and the addresses, and then you will also tell us the training sites that you provide to us if they're a primary clinical site. And if they are, you are going to provide to us the payer mix. So just like they collect information on your payer mix, we do as well. You will be scored on that as well. So we will score you on your payer mix population. We will score you on if your training sites are what we consider to be in areas of unmet need. For areas of unmet need, we are looking at we are looking at HPSAs, MUAs, MUPs. The Commission has their own designation called a primary care shortage area. So if a training site happens to fall within that area, you will get credit for that. But we are also looking beyond that. Say you have your residents rotate through a county clinic that doesn't happen to fall in a geographical area of unmet need, then you may get credit for that training site as well. So we look at county clinics, we look at community health centers, we look at the VA, we look at the prison system. There's many other underserved populations that may not be captured in a geographical area of unmet need. So placement of graduates in areas of unmet need. We know that you're all limited in where your graduates go, right? You only have so much, influence over where they end up practicing. But as much as you can, we want to know that you are encouraging your residents to go on to practice in areas of unmet need. And we see that happening through the training that you provide to them. The more exposure you provide to them to underserved populations, hopefully they will then go on to serve those populations. And then recruitment of underrepresented minorities. I know that there was discussion earlier about underrepresented minorities. The commission has their own definition of what underrepresented minorities are. And so for each, as part of our application process, we ask you to tell us about each of your graduates. So we want their name, we want their MPI, we want their race, their ethnicity, where they're practicing at, and you will be scored based on their race and ethnicity. That is a part of the scoring process for SongBrown. Okay. So this is the available funding for SongBrown. SongBrown in the 1920 budget, the governor just appropriated $31 million annually to our program to fund primary care residency programs. And it's broken out as such. For existing programs, we set aside $18.7 million to support those. Teaching health centers, it's $5.7 million. Expansion programs that are permanently expanding their residency slots, there is $3.3 million set aside for that. And new programs. So the commission wants to encourage new programs to apply. So in that effort, they have set aside $3.3 million. And this money is to help you. You know, our understanding is that starting a new program is very expensive. So we are going to help new programs by helping them offset the cost of becoming accredited. New programs can apply for up to $800,000.
That's a good question. I was confusing you with the last folks that were here. So St. Cedar Health did receive that. Thank you very much.
You're welcome.
Our internal medicine program was accredited. Thank you very much.
You're welcome.
We will be applying for operating funds, and we were having a little trouble seeing where in those four then we are. So we haven't graduated anyone. We're a paper. We haven't started anything.
Right. So you are next you are going to apply for, so what type of, you are a community, an FQHC?
So they applied last 20.
Yeah, so we got the 800,000.
Okay, and then you just applied, right? Did you just apply as well?
Well, I'm hoping we picked the right thing, but I'm curious now.
Okay. Okay, so I think that you applied for existing slots and may have applied for teaching health center slots as well?
Yeah.
So you are eligible to apply for both of those buckets of money.
People are going to be glad to hear that.
Okay. Okay, so our application process is a competitive process. We, like Lupe was just speaking about the demand versus what's available, we run into that problem as well. We get way more program applications than we could possibly award everyone. So let's move on here. So this is what, we have only been funding new PCR programs since 2017. So here you can see overall in all of SongBrown for PCR, we awarded $52 million 12 or almost 13 million of that going to new programs. We really, on average, we probably get 7 to 8 new program applicants a year. We would love to get more. The commission would love to get more. They want to fund new programs. For teaching health centers, we have been funding teaching health centers since 2013. So in that time, we have awarded $87 million in Song Brown, and almost $21 million of that have gone towards teaching health centers. The commission loves teaching health centers as well, loves their mission, loves what they're doing in the community. Okay, so I was asked to talk a little bit about application submission best practices. So in the event that you would like to submit an application, let's see, new programs funding. Say you're getting off the ground and you want to apply for new programs funding. That is a longer application. It will have qualitative and quantitative information that we're going to collect from you. So my advice, if you are planning on applying for new programs funding, is read the questions, provide responses. We need to know, we know that you're new, and a lot of the things that we're asking you, you're not going to have in place yet. But tell us what you are going to do and describe it well. New programs applications are reviewed by a review panel of subject matter experts, and the things that we hear, the feedback that we get from them after a review cycle is wasn't described very well. You know, it's a lot of words, but nothing behind it. Those are the kinds of, you know, responses that we get from them when they're providing feedback. So, and the other thing, if you are going to apply, is read the category requirements. There are requirements, eligibility requirements for each one of these buckets of money. If you're not sure, don't guess. I would suggest that maybe you don't know. Should I apply? Am I eligible for new programs funding? Am I eligible for teaching health center funding? Am I eligible? Apply for all of them. It's all in one application, except for new programs funding. That will, if you decide to do new programs in any of the other 3 categories, you will be submitting 2 applications. But staff will make the determination once your application is submitted which bucket you actually qualify for based on all of the requirements that you meet. Know what resources are available to you. Out on our website is our glossary of terms, is a technical assistance grant guide, is a PowerPoint presentation. We also do webinars prior to the release of our application. So I encourage you to attend those if you're available and can do that. Be proactive. Know when our application is released. You only get 30 days to complete an application and submit it. So if you have any questions during the application process, reach out to us. We're more than happy to help you. We want you to complete a good application. And then provide complete and accurate graduate and training site information. So as a newer program, the only information you're really going to provide to us is your training sites. If you don't know, I would hope that you would know, obviously, the name of your training site and exactly where it's located. But if you are successful and get awarded and you want to come back for future Song Brown funding, a lot of programs, when they're providing us with their graduate data, they have some annual survey or something that they do of their graduates to get all of that information. But we see a lot of misspelled names, misspelled addresses, which can really mess up the process of determining if it's in an area of unmet need or not. Some people don't even attach a name to an address, they just put in an address. Well, that's not very helpful to us when that address may not be in an area of unmet need, but if you had just told us, that it was a county clinic, we would have verified that and given you credit for that. But with no name, we're not going to put too much effort into trying to help you out. We do our best, but this year we got 92 applications. And so it's a little hard to take the time to help everyone get all of their information correct. And then allow sufficient time to properly fill out your application. We see people, like I said, you only get 30 days. We see people who wait until the week before it's due and then are hit with the amount of information that they have to provide. And so we'll just, submit. Well, anymore you cannot submit without providing every piece of information that we asked you for. In the past, you could have done that. But that's where we get the no names, the wrong addresses and such, is because people have waited until the last minute to complete their application. Okay, so here's our contact information and the Song Brown email box there. And if you go to the Song Brown webpage, we are located under Loans, Scholarships, and Grants. And that's it.